Pulmicort is long-acting. Pulmicort has cortisone in it, hence the name Cort. We found Pulmicort was much more effective than albuterol, one puff once or twice a day. By adding these three cocktail things on, now if you said, well, I had a friend who had COVID, all he had was diarrhea, or all he had was headache. Yeah, we wouldn't give the cocktail to them. This was if they have respiratory symptoms. But the vast majority of COVID presents with respiratory symptoms. COVID puts out cytokines and puts out an inflammatory response where your body's making tons of mucus. Geographically, mucus obeys the laws of physics. Gravity takes it down into bronchial tubes, into chest. You get a double pneumonia, it's no picnic. Our job was to keep the lungs open with the inhalers and get rid of the mucus. The other thing that we know causes mucus is activity, so that's why you're supposed to be bed rest. So between bed rest and taking our cocktail, they were able to keep the lungs open, and I think being able to fight the mucus that became a lung eater actually was one big reason we didn't have more deaths or hospitalizations. And as they say on the Channel 13, but wait, there's more. What I call the COVID threesome: zinc, the double Z's, and vitamin D. Everybody got zinc, pretty high doses, and that sounds a little like populism, like, oh yeah, everybody's using zinc. Zinc made a lot of sense. First of all, it's very safe, it's not very expensive, and zinc has been shown to reduce the number of days of the common cold. One of the viruses that cause the common cold is the coronavirus, the plain, not COVID, but the plain coronavirus. So, since it made sense, zinc would lower the number of days you have the common cold. Can't hurt to put it with coronavirus of COVID. I can't really tell you for sure it saved any lives, but we were just going shotgun here, and I think it was a reasonable thing to use. Now, the Z-Pak is an antibiotic, and a lot of people who know these kind of things said, well, why would you give me an antibiotic for a virus? Because COVID is a virus. Well, a Z-Pak, zithromycin, has properties different than most antibiotics. It's the drug of choice for mycoplasma. Mycoplasma is what they call a near bacteria, or a near virus. It's kind of like mycoplasma has properties of viruses and bacteria in one bug. So, you could imagine some kind of, bats are mammals, but they have properties of birds because they have wings and they fly. So, mycoplasma has some properties of viruses and some properties of bacteria. The drug of choice against mycoplasma is zithromycin. Works right away. So they've used Z-Paks for many, many years against any kind of weird virus, thinking it can't hurt, and it might, if it has any effect like mycoplasma, it's worth trying. The second reason we used it is we were seeing a huge number of pneumonias, and Z-Pak can help prevent the pneumonia, because these pneumonias were bacterial pneumonias. Z-Pak was for bacterias. So we felt the double Z's were a good combination to help prevent pneumonia. Vitamin D, it sounds popular, vitamin D, sure, why not? But a lot of studies showed the lower your vitamin D level, the worse case of COVID you have. I've never been a big believer in testing vitamin D in healthy people. I find it's usually normal. Normal is 30, but they don't get too excited till you're under 15. But we wouldn't even check the vitamin D, we put everybody on it. I was not a believer that it really had anything to do with COVID, but when I was admitted to the hospital, they checked my vitamin D, my number was 8. So I became a believer really quick. Wow, maybe that's one reason I have such a bad case. So I'm still taking vitamin D today, and I believe it was very helpful for the COVID threesome. Now what we just put up there was our standard therapy for everybody. But then there were these people who were sick. Remember, a lot of COVID, I'm sure people in the room or you knew people, it was kind of like the flu. They had aches and pains and cough and sneezing and sore throats, and they were that way for a few days to a week, and then they got better. And they were the ones we gave the first couple slides to. But then there's this other group of people that are really sick. They aren't getting better right away. They're going on 5, 7, 8, 9 days. They're coughing up a storm. They're probably getting pneumonia. doing bed rest, but not because we told them to. They're doing bed rest because they can't get out of bed. They get out of bed and they fall over. So for them, we gave steroids, Decadron or Medrol. You've probably heard a lot about Decadron because that's in all the different studies they do for COVID. And Medrol is something we've used a lot over the years at Caduceus. The main difference is Decadron is a long-acting steroid and very potent. Medrol is shorter acting and less potent. So depending on their own, how sick they were, we would pick one of the two. Usually we pick Decadron. It works primarily as an anti-inflammatory because COVID's pouring out inflammatory cells, and that's what's causing the mucus in the chest. So we want to give an anti-inflammatory, something to fight the inflammation, so that's where Decadron comes in handy. It has been well documented, and it's been proven scientifically in controlled studies that the Decadron will reduce morbidity, meaning how sick you are, and mortality, your death rate, but only in patients that were hospitalized and on oxygen. Currently, there is no official body recommending Decadron be used in people who aren't in the hospital or are not on oxygen. But we found we were having excellent results with it as an outpatient, to the point where we tried the cocktail and the double Z's. Most people got better. Those that didn't, and they were kind of going the wrong direction, we put them on Decadron, and they pretty quickly feel a lot better and get better quickly. So Decadron is definitely a mainstay of treatment. There is no rule or law against giving it as an outpatient. If any of you have had sinus infections, good chance you got it for your sinus infection. So it's very safe and legal to give it. But currently, as far as the studies go, it's primarily been shown to benefit people in the hospital on oxygen. So we've got to talk a little about Plaquenil, also known as hydroxychloroquine. It's impossible to talk about this without talking about the politicization of treatment for COVID, because that's exactly what happened with this med. I'm biased because I've used this my whole career. I'm very comfortable with it. Now, of course, I haven't used it for COVID my whole career because COVID came out in 2020 and I probably first prescribed it in 1980. I'm very familiar with the drug and very comfortable with the drug. People forget that it was used successfully. Remember, for those who were 2 weeks ago, SARS-1 in 2002 that hit China for a mutated bat. It was a corona mutation. SARS-1 was treated successfully with Plaquenil. Then there was MERS, remember the Middle Eastern virus? That was a mutation as well, also from bats, and that had good response. It had good response against Plaquenil. So using Plaquenil for COVID had a logical scientific basis behind it. It wasn't just something they picked out of the sky. Scientists said people are dying. This is March, April, May of 2020. We don't have nothing. We have the Z-Paks, vitamin D. We've got nothing to fight this with. Plaquenil worked against SARS-1. It worked against MERS. Let's give it a go. It's been used safely for many decades. I think it actually came out in the 40s, so going on 60, 70 years, for lupus and also malaria. And now if you're saying, well, how much malaria have you treated, Dr. DeNicole? I'd say, well, in my whole career, probably 2 cases. But it's used frequently for malaria prevention if you're going on a trip to Africa or the Amazon. We give Plaquenil to help prevent malaria, and I've given it a lot for that. But in lupus patients, it's been a lifesaver, literally. It's very, very good for lupus. People in wheelchairs get out of wheelchairs. People in kidney failure get their kidneys better on Plaquenil. And there's really no debate about that. Ironically, when it came out, it was only used for malaria. Some scientist in a hospital somewhere said, well, it does work as an anti-inflammatory, maybe we should use it for lupus. And he did that off-label legally, and it worked for lupus. So why it was okay to use it off-label for lupus, but it wasn't okay to use it off-label for COVID, I'm not sure. But it's a very safe medication. It works by calming the immune response, and it actually has been shown to help prevent viral replication, which you need to fight COVID. So we began using it, again, for the reasons that we had nothing else. Now, we're pretty apolitical, at least I'm very apolitical, so I don't even read the front page of the paper hardly. So I didn't know it was any big deal about using it, but I was using it and it was working. From March to May of last year, we used it for moderate to severe cases with great success. Our first 18 patients, 16 had almost immediate response. And we knew it was working because they were on the double Zs, they were on the COVID cocktail, they were still struggling, they were coughing, they had high fevers. Within 24 hours of the Plaquenil, dramatic improvement. However, starting in June of last year, we noticed it wasn't working very well. So why was that? Well, my theory, and it's a good theory, but I don't have it proof, is that the virus mutated. We've seen this virus mutate so many times. And as the virus mutates, it mutates to be able to fight off things that it worked for. So where Plaquenil worked really good on the original COVID strain, it didn't seem to work too well starting in June. Is this where you have the slide, Tina? Is Tina still here? Tina here? Okay. Is this where you have my slide? Because I don't see it.
Probably not.
Okay.
Just because,
So forget about it.
yeah.
Okay.
Just be safe.
Okay, we're forgetting about the next slide. We're going to this slide. Okay. In April and May, 2 respected medical journals raised alarm about Plaquenil. They're so respected, you've probably heard of them. New England Journal of Medicine and Lancet. Lancet's from Britain, New England Journal's from New England. These are extremely respected journals. They put a lot of time and attention in screening. Now, these are peer-reviewed, meaning doctors reviewing other doctors. And they said that the effectiveness was so low, it wasn't worth the danger and not to use them. How do I do this here? Okay. That was in April and May, as we were using it here with great effect. So I didn't quite understand how they could say it wasn't working when it was working for us. Now granted, we're in the West Coast, we had a very limited number of patients, maybe that was it. However, in June, both journals had to retract the articles publicly. Front page of the Times, front page of the Wall Street Journal, that they took back. The editors of the Lancet and New England Journal said, disregard those articles. Their quote was, "We cannot vouch for the veracity of data." That sounds a little like, what are they talking about? I'll make it very easy for you. The people who ran the article, who wrote the articles, faked the results. That's why they couldn't do the veracity. Now, if you're thinking, how many times has New England Journal or Lancet had to retract an article? Well, I was in medical school starting in '75, and I have never, ever, and I read these all the time, I've never heard of any journal retracting an article like that. Because before they'll put it in their journal, they spend so much time studying it and double checking the results and everything. So how the authors got it through, hard to say.
Did they disclose the authors and the?
Oh, yeah.
And
Yeah. Mhm.
where they were from? And what-
They admitted that they couldn't, that they fudged the data. No, that was. So, on top of that, right when these articles came out, the FDA retracted the emergency use authorization they had given for it. And again, they were basing it on the cardiac side effects, which are very rare. We're talking about maybe 1 in 10,000 cases had a skipped heartbeat. So this drug, again, was used very safely for decades. And why now, all of a sudden, the FDA won't give it an emergency use authorization? 2 respected journals had to admit that they caught the authors in a lie. So I'm trying to be as factual as I can here without being accused of being on right or left of the middle. But the head of the FDA was Dr. Stephen Hahn. He resigned shortly after all this happened. He admitted, after he resigned, that he was pressured by left-leaning politicians to not validate a drug that then President Trump took himself preventively, which he shouldn't have, and touted it in some news conference somewhere. It got worse for us personally here at Caduceus. I don't know how many of you are familiar with Nextdoor. It's an app or something on your social media. The Laguna Beach Nextdoor promoted a boycott Caduceus campaign because my main practice is in Laguna Beach, and I became known as the doctor who's giving Plaquenil, so therefore I must be pro-Trump. Laguna Beach, FYI, is a very blue city. So I had to read all these things about people boycotting me because I'm pro-Trump because I gave Plaquenil. I gave Plaquenil because it worked for 3 months. I stopped using it when it stopped working. A Cochrane review is very, very respected. Cochrane review is done as a watchdog. They go through every bit of data they possibly can. They publish all their findings. And they, in April of this year, could find no studies supporting Plaquenil after May of 2020. They didn't start looking at the data until June of 2020, and that's when we found it not working. So you say, well, do you support Plaquenil's use? Currently, no, I don't. I think we've given it a few times on request, but it doesn't seem to have worked for over a year, or for about a year now. There are no peer-reviewed large prospective studies on this at all. So,
Is it possible mutation?
yeah, I'm sure that's what it was. That's what my slide said. Okay, let's skip on to another treatment. Oxygen. There's home oxygen. Home oxygen has very little data to support this, meaning maybe you have a friend who's coughing really bad. They buy a little pulse ox machine. I carry mine with me right here. So they put this on their finger and they check their oxygen, and it's under 90, which is bad. And so they get on the phone and they call everybody they know to try to get a tank of oxygen in their house. By the way, it's very hard to get home oxygen because the criteria is very strict, and insurance don't cover it unless the numbers are really bad. We did use home oxygen, and we've had mixed results. There are patients that my wife Mary believes were helped tremendously from it. I am biased. We had a tank at PDQ, which is our urgent care, that Mary went and grabbed for me when I had it. It didn't do anything for me. So I'm personally not a big believer in home oxygen, but I guess for some people it did help. The mainstay of therapy and the life-saving kind of oxygen is called high-flow oxygen. Now that's much different. That is only meant for hospitalized patients. You can't really take high flow anywhere else but hospital. And it prevents mechanical ventilation. Mechanical ventilation is, put in better English, when you're being intubated and a breathing machine breathes for you, you're on a ventilator. So the idea is to get people better before they need that. So high flow oxygen is what they use to help you prevent you from being intubated. It kind of pushes the oxygen to eradicate the dead space in your lungs. A very weak analogy might be holding a fan on low up to your face and then cranking it to high, and as you got the higher flow. So it's high flow oxygen. But it's very dramatically higher. For example, if you're put on 100% high flow, which is as high as you can get, you can't go any higher than that, you're getting 60 liters a minute of oxygen. Comparison, when you see grandma with the little nasal cannula, the little things that go in your nose in the hospital when she has pneumonia, she's probably on 3 or 4 liters a minute. The nasal cannula can only go to 6 usually. So 1 to 6 you're on, that's low flow. But if you're on the high flow and 100%, you're on 60 liters a minute. So you could see the tremendous improvement with numbers you'd get being on high flow oxygen. The pros of it, it's safe, it's been studied, side effects are minimal. It improves comfort, and it reduces the need for intubation, and has also been shown to reduce mortality rates. So most doctors, myself included, are big believers in high flow oxygen for COVID. Of course, to get it, you'd have to be sick enough to be admitted. So,
Is it 100% oxygen?
well, when you go in, they start you whatever the doctor wants to start you on. So I had high flow oxygen, and they started me on 50. The next day I was on 100 because 50 didn't do it. So, so they're not sure because they've never had a bug like COVID before. So they have no experience in running high flow oxygen more than a couple, 3 weeks. So that's what they told me. They said, we can give this to you for a couple weeks, 3 max. If you don't improve in 2 or 3 weeks, you'll have to go upstairs. They didn't mean heaven. They meant to the they meant to the ICU where I would be intubated. So I knew in a couple weeks if I didn't get better, I'd be intubated. So that was a little scary. So they have like a 2-3 week window when they start you on high flow oxygen. Also, it aerosolizes the COVID that you have. You have COVID in your lungs and mouth, and you're on this big, huge mask, and it's got tubes coming off each way, and there's aerosol coming off. So nobody can come in the room without putting, to me it looked like a hazmat suit. It's big, huge space suits with big bubbles and everything on them. So you tend not to have a lot of visitors. You can't have visitors anyway, but even the nurses don't come in the room because there's so much work to come in the room because of the aerosolizing. So that's high flow oxygen. Now, if that fails, then you need to be mechanically ventilated. Mechanically ventilated means something else is breathing for you, or high flow oxygen just blows the oxygen harder. So BiPAP is like CPAP for those who maybe use CPAP or use somebody for sleep apnea. BiPAP has 2 settings, one for inspiratory, one for expiratory. It doesn't breathe for you, but it assists your ability to breathe, so it's considered technically a form of mechanical ventilation. It's not painful, but you could get hooked on it. You could get to where your body really needs it. They'll usually use BiPAP for a week or 2 max, and then if you are still on BiPAP, so you get to 2-3 weeks of high flow oxygen. If you don't do well on that, then they put you on BiPAP for a week, 10 days. If you're still running bad oxygen levels, then they're gonna have to put you on mechanical ventilation, meaning intubate you and breathe for you. There's a high mortality with intubation. I haven't seen numbers recently, but in December when I was hospitalized, if you were intubated, there was a 50% mortality rate. So you really didn't want it to be that sick. You really wanted to avoid the intubation. But it can be life-saving because if you don't breathe for them, they'll stop breathing on their own. So, word about remdesivir. Remdesivir is an IV antiviral medication. It's FDA approved for 12 years and over. Notice I said FDA approved, not emergency use authorization. FDA approved. It means the FDA has studied it every which way, up and down, determined it was safe and efficacious, and gave it a total clean authorization. But you have to be hospitalized per the FDA. Now it's given IV. If you said, well, couldn't a home health nurse give it in your home? If you know who to pay off, maybe they can do that, but you can't get your hands on this stuff. In December, when I was hospitalized, at least half the hospitals in Orange County had no, they were out of it because remember back then, the numbers are going through the roof. As far as I can tell now, every hospital does have it, but in India, there's zero. Like India's having such a huge epidemic, they couldn't keep it on hand. So there's like not 1 dose in the whole country of India right now. Remdesivir is generally safe. Antivirals usually are. Recently, a large Johns Hopkins study came out showing a much improved recovery rate if you took IV remdesivir. It's 5 days, by the way. But interestingly, there was no reduction in the mortality rate, the death rate. So it does help you get over it quicker, and it gets you not as sick, but it probably won't save your life. Despite this, the WHO has never recommended it, which I can't figure out. Well, I can figure it out. The WHO is the World Health Organization. Remdesivir is basically supplied in the United States. So there's so many countries that couldn't get remdesivir. In Milan, Italy, when they had their outbreak, Italy couldn't get their hands on it. When you heard about outbreaks in China and Hong Kong, they couldn't get their hands on it. Now India can't get their hands on it. There was a recent huge epidemic in Brazil. They couldn't get their hands on it. So it's my theory, the numbers are so good using it. My theory is the WHO doesn't want to endorse it because there's so many countries in the world that can't get it. So they're kind of just holding back, I think, because its availability is...
Is it due to cost?
No, it's just the remdesivir machines can't make enough of it for right now. I know it used to be expensive, but I think the price has come down quite a bit. I don't think cost is the issue. Then baricitinib. I don't know why more people haven't heard of this. It is considered one of the mainstays of treatment, but again, how often do you pick up the LA Times or Wall Street Journal and see this in the front page? Never. You see remdesivir, but you don't see this. But the numbers are extremely impressive. The FDA has approved it, but it's the EUA, emergency, not full. But it has to be given with remdesivir. And it's a pill, a tiny little pill. So it's not IV. You say, well, then you could take it at home. Well, then you can't take it at home because you got to take it with remdesivir, and that's only in the hospital. And actually, they will not give it to you to go home with. So once you start it, you're on it in the hospital. It is a 14-day course if you're in the hospital 14 days, but if you leave after 5 days, you only get 5 days of it. The studies have been done showing it's especially effective if combined with high-flow oxygen. So you get a little feel for this here, that by itself it may not do a whole lot, but combine it with remdesivir and combine it with high-flow oxygen, it really does help. More so than those two by themselves. It inhibits the immune cascade we talked about, and it reduces viral replication, like we mentioned before with some other drugs.
Is it a US pharma?
Mm-hmm. So, we now know, and we've seen this on the COVID team here at Caduceus enough times that this slide is something I got off a medical textbook, but we've seen it so often I totally agree with it. Most COVIDs have an initial syndrome of an upper respiratory or lower respiratory infection as the viral load increases. Viral load means the blood level of COVID in your blood that goes up. Yes, you can get headaches. Yes, you can get diarrhea. Some people have heart backache, that's it. All that's true, but the vast majority have an upper or lower respiratory infection. However, 20% of COVID patients after a week progress to a double pneumonia with low oxygen levels. Not day 2 or 3, day 6, 7, 8. And actually, between day 2 and 3 and day 6, 7, 8, they were probably feeling pretty good. Matter of fact, they might have tried to go back to work, or maybe they, cheated a little on the cocktail and all that. But it's the second whammy that gets 20% of them. This is characterized as a massive immune response with lung damage and possible ARDS. ARDS has a 50% mortality rate because it causes respiratory failure. They basically drown in front of the doctors and nurses in the ICU. It stands for acute respiratory distress syndrome. Basically, COVID is pouring out cytokines, mucus pours out of your lung pores, the lungs fill up, you feel like you're drowning, and that's the danger of these 20% that get to the double pneumonia. So, the literature has spoken. Every study, more and more, is showing the best treatment is the triad of remdesivir with Decadron, with baricitinib, and I didn't put it on here, but a fourth thing, with high-flow oxygen. So it actually be the 3 meds and high-flow oxygen is the mainstay of treatment. The odds are, if you have to go through all those, it's your best chance at survival.
Are they all made by the same pharma, or are they?
No.
They're
I couldn't tell you the names. Well, Decadron is generic for the most part. Okay. Well, let's talk about other things you may have come, if you saw the title was treatment, you might have said, oh, I want to go hear about these other ones. So let's talk about other ones you may have heard of. About 3 months ago, I was inundated with emails about ivermectin. There was some YouTube video that got out. Some doctor, actually a bunch of doctors gave a little speech on it. This one doctor had anecdotal evidence that out of 20 people he gave it to, they all got better right away. It was touted as a miracle drug by these select doctors. I was actually encouraged when I watched the YouTube video, oh yeah, that's pretty good, we should try that. However, none of the evidence was peer reviewed, meaning there was no study published in any medical journal at all. This was anecdotal, meaning these doctors used it and said, hey, it's working, which in truth is what we did with Plaquenil ourselves, so it's not, I mean, do what you have to do. I've used ivermectin in my career many times. It's used for worms, it's used very well for scabies, it's used for head lice, and it works very well for rosacea. No one really knows why. So I'm very familiar with ivermectin. I've used it. We used it here in our COVID team. I think, I'm pretty sure 0 people got better with it out of 6 or 8 times we tried it. So I'm not a big supporter of it. The main support came from social media, Facebook, Instagram, and the app called WhatsApp. I don't know if any of you guys are on WhatsApp, but there was a huge ivermectin WhatsApp group that promoted its use. And there was a lot of YouTube videos on it too. So the FDA advises against it. I'm not sure why they're advising against it, because there's just not enough data, but it is not FDA approved in any way. The main problem with ivermectin is everything you heard about, the sample size is very small, and it's anecdotal evidence for the most part. So if any of our patients do get COVID now and they ask for ivermectin, we will tell them all this, and if they still want to try it, we'll give it because it's safe, but we haven't seen it work. Now there's monoclonal antibodies. I was watching TV, you know, whatever TV channel where you watch the old TV shows from the 50s and 60s, like Leave It to Beaver and all that. I was watching that, and there was a commercial. This old lady was coughing, and the daughter says, "Mom, you have COVID. You should go get help." And she goes, "What can I do? Nothing I could do for COVID." "Yes, you could take monoclonal antibodies." And then afterwards, in big letters, came up, Bamlanivimab. So that company sponsored that commercial. Monoclonal antibodies actually had a good reputation. Trump took it when he had COVID. Whether that helped him or not is debatable. But because Trump took it, and actually most other leaders, I think the guy in England, Boris, what's his name in England, I think he took it too, and there were several celebrities that took it, so it got a lot of play. And I was actually pretty impressed. So when I went to the ER, I said, "Can I get monoclonal antibodies? My numbers are pretty bad." Well, it turns out if they give you monoclonal antibodies, they can't give you remdesivir and all the other stuff, the Decadron. They could, but they're not supposed to. So it's like one or the other. And there just wasn't enough data on monoclonal antibodies, in my opinion, to forego the other ones, which have been shown to help. It had an EUA from the time before Trump took it until last month. And they retracted it because they were finding the initial results they were seeing with it just didn't hold. These are laboratory-made proteins. They mimic our immune system's ability to fight off COVID. The concept is very sound. I mean, this is not hocus pocus or anything quacky or anything like that. It's just that it's kind of like Plaquenil for us. It was working, and then it stopped working. So, like Plaquenil, mutations had probably occurred and why it's not working too well right now. To get it though, you have to be in a high risk category. I thought I qualified because I was over 65, diabetics, COPD, asthmatics, people with heart or lung disease, they're the ones who are supposed to get this. Trump got it probably because he was president, but he was over 65, so he did qualify. The other thing is it must be used early. And by the time I hit the ER, I was on day 8, 9. And they said that was too late. It had to be given like in the first 2, 3, 4 days. And in truth, that's when Trump took it. Trump took it the minute he was diagnosed. So it is possible to do it as an outpatient though. So right now, I don't really know anybody who's promoting monoclonal antibodies. We aren't using them here. And if somebody were being admitted and said, "I think I qualify, I'm 68, I have COPD, I'm only on day 3, shouldn't I have it?" I'd say, no, go back to the Trinity, go back to Decadron and baricitinib and remdesivir. That's what you really want. And you can't take this if you take those. So, convalescent plasma. was very, very promising. When I was in the hospital, my wife begged to give this to me. I didn't get it. It's also known as survivor's plasma. It contains really high levels of antibodies from survivors. It has to be a recent survivor. This first became very popular with Ebola. When Ebola was ravishing Liberia and Sierra Leone and all the African areas, that's where you got this terrible virus that made you bleed to death, basically, very fatal, 90% fatality rate. And no medication was working. We're talking about American missionaries and American doctors that flew there to care for these people were dying, going over there to get it. So, more just out of frustration and Hail Mary pass, they took survivor's plasma out of one of the 10% that survived it, put it in the people who were bleeding to death, and lo and behold, they got better. So convalescent plasma has a good track record in other diseases. It was used initially with pretty good results, but these were anecdotal, no large-scale studies. And if you look at the literature, the results just aren't conclusive. That there's not enough data to support using it, because just like monoclonal antibodies, if you take this, you can't be doing the other things too. So you can't be on remdesivir, you can't be on vorasidenib. So the studies do show faster recovery, but no improved mortality, and that's the reason you want to take it. Basically, you want to live. And again, just like monoclonal antibodies, you have to use it early. By the time you wait until they're almost going to be intubated, it's not going to work. So let's just look at some of the pure facts. If you have one risk factors, and if you were here 2 weeks ago, I rattled through them, but I'll say it again: diabetics, hypertensives, heart disease, COPD, asthma, or seniors, lower economic classes, and all minorities, but for some reason, especially Asians, because of the China thing, are all considered high risk. If you have one risk factor that I just rattled off, your hospitalization rate could be, in some studies, as high as 40%. And the ICU rate, 15%. So the idea is to not be in a high-risk category. Unfortunately, when you look at people who've died, and I'm talking about, you read in the newspaper, a friend of a friend died, and a lot of these people are young, otherwise healthy people. But if there's no risk factors, the hospitalization rate is much lower, 10%, and the ICU rate's only 1%. If there's one risk factor, mortality rate sits at 10%. If there's no risk factors, mortality rate's at 1%. So in order to avoid the ICU, in order to avoid death, again, we'll go back to remdesivir, Decadron, baricitinib, high-flow oxygen. That's the main treatments that are working. So we'll summarize. 20% of COVID cases do progress to double pneumonia after 7 days. Scary number, and this is blending in both high and low risk people. If you're high risk, it's a much higher number. We believe here at Caduceus that aggressive follow-up and symptom management did help keep our numbers better. We feel strongly about that. The mainstay of treatment, if you have low oxygen levels on the little machine I just showed you, is to take high flow oxygen. Not low flow, not at home, high flow in a hospital for up to 2 weeks. The trinity of therapy, I've said it many times, but I'll say it again because repetition is the best teacher. Remdesivir, Decadron, baricitinib, those three together, life-saving. Monoclonal antibodies, despite the commercials you might see, convalescent plasma, despite some anecdotal reports you read in the paper, they're promising, they're hard to find. We actually tried to find monoclonal antibodies recently. Couldn't find it anywhere. Probably will not be one of the home runs for COVID treatment, at least in this current siege. Any treatment other than the above, and I don't have high flow, but there should be high flow oxygen up here too. Any treatment other than something we already mentioned here has no proof and is probably bogus. Now I read my medical stuff every day, my medical journals every day on my phone. I get them, and it works. And so just a couple days ago, I didn't put it up here because it's not worth it, but it said Lipitor, you know, the drug you use for cholesterol. Lipitor to be touted as an anti-COVID drug. So I'm thinking, why would a cholesterol drug help COVID? Well, the idea was, what I didn't put up here, I did 2 weeks ago, but remember one of the leading causes of death beside respiratory failure are clots, heart attacks, strokes, pulmonary embolus, phlebitis, all that. So they're thinking that the Lipitor will prevent the clot from forming because it's kind of an anti-heart thing. But when I read the data, it was very weak, very anecdotal, and it's just too good to be true that you could take Lipitor and cure COVID with it. So I'll be happy to take questions, but if you say, my friend said that this works, my friend said that works, if it's not one of these three meds and it's not high flow oxygen, I have no confidence it's going to work. But we still start off with Z-Paks and zinc. We still start off with a cocktail. We still give everybody an inhaler, and we think you got to keep the mucus out of the chest. I think that's it, right? And remember, only remdesivir is FDA approved for COVID. That's it. So when you go talk to your friends and you said you went to a lecture on COVID treatment and they go, oh, ivermectin and monoclonal antibodies. No, the only FDA approved medication, remdesivir. That's it. Yes, Tina. Oh, Tina will read the questions and say.
I went through all of the questions. I know a few of you had asked about getting these on demand, if you will, or being able to rewatch it on video. We do have a YouTube channel at Caduceus Medical. If you are not already receiving our May newsletter or our regular newsletters, you can email me after and I'll add you to our newsletter database so that you get them. I had just shared in the newsletter about a week ago a video from the first event and a link to our YouTube channel. So yes, absolutely, we'll have those available for all of our events. So I know that there were a few of you that asked that, so I just wanted to make sure that you're aware that's YouTube at Caduceus Medical. Yes, ma'am?
I tried at Caduceus Medical and it didn't work. I searched it multiple times. I even tried to add a group. And
Okay, well, how about if I talk to you one-on-one after and make sure you can find it? Yeah.
I'm telling people to do that, it doesn't work.
Okay, well, we'll talk about it after, and I'll as soon as we're done here, I'll come over and help you find it. Okay, so do you want me to, okay, perfect. So Dr. DiNicola, the first question is, are you better protected by recovering from COVID-19 or the vaccination?
It always bugs me when I go to lectures and the lecturer says, that's a good question. The only reason it's a good question is if he knows the answer to it, because that makes it a good question. That's a good question because I've wondered the same thing. Initially, most of the studies showed that the vaccine gave better protection than natural antibodies. I'm not a believer in that because I just know my microbiology, I know my immunology from med school. Natural antibodies are really, really good. The guy upstairs knew what he was doing when he designed us, and that's why when you get measles and mumps and chickenpox, for the most part, you don't get them again because natural antibodies are so good. Now, you might say, well, how about the common flu? The flu gives you natural antibodies, a year later they're gone. That's because the flu mutates so quickly that you do have antibodies that'll last you for many years for that last year's flu, but not for the one that mutated coming next year. So I kept searching the literature because I'm not seeing patients currently. I have time to surf the internet for data. And the more I searched, I found that natural antibodies had a higher success rate than vaccine antibodies. But I don't think it matters to answer the question because one is 99.2% and one is 98.8%. When you get to that close of a horse race, does it really matter which one's better? They're both excellent.
What about longevity of either one?
They don't know yet because we've only started now the antibody, we've checked antibodies since last May when they became available to check. And we haven't found anybody over a year yet with natural antibodies. But we've had it people 6 or 8 months, so you know, that's good. The vaccine, they were saying, well, we probably need a yearly booster. But they admit, and Johns Hopkins is one of the first ones that came out and said this, they said, we won't know. We started giving the vaccine in January. We won't know until the fall. If it made 9 months, 8 months, 6 months, we might need every 6 month boosters. We just don't know. So that's why we've said in our blogs, for those who read our blogs, we advise everybody to get a monthly antibody check so you know when your antibodies fail. I didn't take the vaccine because my antibody levels are so high from my illness. I was afraid of clots and things like that because a lot of the clots were in people who had very high antibody levels and then took the vaccine. So I check myself monthly, and as soon as my antibody level starts to fall, I'll immediately get the vaccine. But if you have either one, if you have natural antibodies or if you have the vaccine, your protection rate is very, very high. So I don't think it matters which is better, but if you look in the literature, you'd see natural antibodies are a little bit better.
Next question is, why is vitamin D important for COVID treatment?
I have no idea. I really don't know. I guess I could Google it and tell you, but then I guess you could Google it too. I wasn't a believer when I read those articles. I wasn't a believer in blood type either. Like blood type A, you're supposed to have terrible results, and blood type O, good results. And you know, I'm blood type A, which is why I had a bad case, I'm sure. And my vitamin D was very low. It does, I know vitamin D can, high doses, act as an antioxidant. And for the clots, you do want antioxidants at work. So that could be part of the thing. Also, vitamin D has been known in higher doses to be an anti-inflammatory, and that's kind of how baricitinib works. So I'm sure it's something in that area, but I don't think it's enough of a cause and effect for anybody really to know how it works.
I'm going to see if I don't massacre this one. Long haulers, understanding that cell-mediated inflammation, macrophage infiltrated, leads to fibrosis in various tissues. We'll just unpack that one first.
Maybe I should read that.
There's a lot.
Okay, we have a biochemist in our midst. Understanding some of the information. Is there any treatment? No, not yet. The medical centers, universities are working really hard for the cell-mediated inflammation. That's why they gave baricitinib, because that's what it works against, but that's not for long haulers, that's for when you're acutely ill. I don't think they've given remdesivir in a study for long haulers. Again, it's IV and it's for use in the hospital, so unless they admitted the long hauler, they wouldn't. So I assume this question is, do they use remdesivir or any other major anti-inflammatories for long haulers? No. Steroids, I have read where Decadron or Medrol might help some of the mental side effects. There are 3 major ones, well 4 we've seen. A general anxiety disorder, basically panic attacks, a major depression with crying and hopelessness, and like a PTSD picture where they act like they have PTSD. And the 4th is what we call a brain fog. They can't find the right words. Their brain kind of is temporarily turned off. It's one reason I'm not seeing patients now is I get that about once a week, or I just have to kind of, I know what it is, I know what's going on. It only lasts an hour or so, but your brain just gets foggy. Steroids have been shown anecdotally to help that. Prednisone is another steroid, yes. And whoever wrote this said yes, until the trial drugs get approved, they're going to need a lot more data on the long haulers, because really they didn't even start using that term until earlier this year. And I don't think the average specialist even recognized long haul till like March or April. So it's a relatively new diagnosis. They have to find the long haulers, they have to categorize them, they have to put them in studies where there's placebo groups and control groups. So there's a lot more data we need for long haulers, unfortunately. Is there more evidence to support amyloid deposits, amyloidosis, as a player in pneumonia? Not that I know of, and I'm not a biochemist. I'm not aware of amyloidosis playing a role in the pneumonia. We have not seen a lot of kidney failure. I would think amyloidosis would cause kidney failure, but I'm not aware of it causing respiratory failure. So, but I'm not an expert in that by any means.
The next one is COVID-19 in pets, animals.
Well, we know they're in bats. If anybody has a pet bat, you might want to get them checked. No, I think I read what you guys read, that they found it in dogs and I think cats too. Makes sense because coronavirus actually started off as an animal virus, not just bats, but a bunch of mammals, cows, and then coronavirus evolved to human transmission. They didn't prove the first case of human-to-human transmission, like smoking gun, until January of 2020. Before that, they thought people who had COVID maybe got bit by a bat or by a cow. Remember, they found it in a chicken mart or a poultry mart. That's where they first, that was a super spreader event, so we know it was in chickens. So yes, animals can get it, dogs and cats can get it. So if you have a sick pet with respiratory symptoms, I'm not a vet, I assume they can check the animal for COVID, I don't know.
What would you recommend for someone with stage 3 kidney disease if they contract COVID?
They can pretty much, well, first of all, that's high risk, so they have to kind of be treated aggressively. Nothing wrong with stage 3 kidney with Sudafed, promethazine, an inhaler. Those are all safe in kidney failure, so that'd be fine. Z-Pak is fine, zinc is fine, vitamin D is fine. So you can do all those initial aggressive things. Definitely be at bed rest, because you do not want to be in the hospital with kidney failure and have to be on high flow O2 and be intubated. You need your kidneys. You need your kidneys working. I guess the one caveat would be to be careful with the hydration, because where normally we'd say drink at least 2 to 3 liters a day of fluid, just flush that virus out of you. With stage 3 kidney disease, you don't want to drink that much because the kidneys are being overloaded. So you might want to watch your fluid intake a little more if you have stage 3 kidney. They actually have found when you're in the hospital better prognosis if they keep you a little, they call it dry. They actually turn the IV down quite a bit and give you diuretics. I think that's to keep the fluid that's building up in your chest at bay, because otherwise your lungs get full of fluid. But definitely, I know there's a higher mortality rate with kidney disease and COVID pneumonia, but it shouldn't affect the treatment. Other than the fluid and status, I think you should be. The Decadron safe, remdesivir safe in kidney disease, and baricitinib safe in kidney disease. So you should be safe with all those.
I think you already viewed budesonide as ingredient in Symbicort treatment or prevention, and then nasal irrigation and flushing.
Flushing, yeah. Yeah, the Symbicort can be used in lieu of the Pulmicort. We did use Symbicort quite a bit. So any of those inhalers with cortisone in it, we found excellent results in. Matter of fact, there was a period of time when I was doing the video visits with COVID patients that I was hearing repeated, this is probably last October, November, repeatedly how Pulmicort or Symbicort was the #1 thing that helped them more than anything. So, definitely improvement there. Full disclosure, I use Pulmicort, didn't do a thing for me. So I guess if you're destined to get double pneumonia, you're destined to get it, and it didn't help me, but it helped a lot of people. We didn't get into the slide, I probably should put on the slide, something we teasingly called pulmonary toilet, which is also more commonly called pulmonary hygiene. But that goes a little with the flushing and the nasal, because if you're congested, you gotta get the mucus out of your body. So if it helps to do the neti pots and the various sprays and flushes, that's a great thing to use. Pulmonary toilet is 3 things, and if you know anybody who has it, they should be doing it. That's where we do percussion and drainage, so we put them on their side, and they turn, cough, and deep breathe. And by turning and coughing, basically think of honey in the bottom of a jar, and you want to get the honey to the top of the jar. So if you put it aside and roll it and cough it up, the thick mucus will come up. Percussion and drainages, you have the patient lie over a kitchen table, take their shirt off, you cup your hands if you're the partner, and you play the bongo drums on their back really hard, and that loosens up all the mucus that's sticking to the alveoli and gets the mucus out, and it helps quite a bit. Pulmonary toilet, what am I missing?
Nasal irrigation
flushing, I think we talked about that, right?
Yeah, we talked about that.
Budesonide?
Budesonide's in Symbicort, so yes,
Yes.
that's.
Do they intubate conscious patients? And if you have had COVID-19 and/or vaccines, are you at risk of getting one of the variants mutations?
I'll take the second one first because I know the answer to that. They thought that. They thought that there were three main ones, and I don't remember, excuse me, but there's the Brazilian one, the UK one, and then there was a West Coast one. The West Coast was a very malignant, very, very bad bug, and I'm sure that's what I had because it first appeared at UCLA in November and it covered California all of December and January. Up to 50 to 60% of COVID cases in California were the West Coast variant. Fortunately, they were worried about it, but fortunately it looks like the vaccines are covering all those mutations. Now, for some reason in India, of course they don't have vaccines, I mean, the vaccines all got used there. In India, they did find that some of the vaccines didn't work against the mutations, and I really don't know why. But here, if you got vaccinated, you are 99+% protected against COVID-19 and all the mutations thereof. As far as the intubation, early in my career, I had to intubate both babies and also adults. It's really hard to intubate somebody who's awake because you get the gag reflex and they're gagging and thrashing their arms around and all that. It's doable, especially if you're good at it, but it's very difficult. So when you hear about somebody with COVID in the hospital being intubated, yes, they were sedated first. They give them like Versed, which is like a IV Valium kind of thing, or some of the same stuff when you get a colonoscopy to put you in a twilight, and then they can put it in because you're relaxed. It's also extremely uncomfortable. When you do wake up, you're gagging. You can't talk, of course. You can't eat or swallow, and you feel like you're choking. And you realize you're going to be like that for 2-3 weeks. So it's kind of a nightmare to go through. So you would fight off the poor doctor trying to intubate you without being sedated. So you would be sedated, but then when you wake up, you would be very uncomfortable.
Does Caduceus continue to guide treatment if their patient goes to the hospital?
Yeah, the hospital system, as you know, has hospitalists. These are specialists in the hospital. So even though we're on staff at many of the hospitals, we're not allowed to take care of the patients in the hospital. But speaking from personal experience, I'm very glad I had doctors who specialized in the ICU management of COVID. There's no way we could have the experience with our limited number of patients to take care of people who are really sick in the hospital. So no, Caduceus doesn't take care of you when you're in the hospital. We stay in touch. We call all the time and talk to the doctors in charge and nurses, and we know how things are going. We translate a lot because the family member, they can't visit because you can't go in the hospital. So we'll talk to the attending doctor, then we'll call the family at home and kind of be the translator. But usually these are specialists in COVID inpatient treatment.
This says, what are local hospitals doing same different?
Now, I'm pretty sure they're pretty much using the Trinity I put up there. I think pretty much all hospitals have read the journals now and they all know that. A few months ago, no. A few months ago, not every hospital had remdesivir. Most hospitals utilized high-fluo tube, but not all of them. Decadron, yes, but different doses. I feel better when I know my patients have had very high doses of Decadron compared to low doses. But I think right now your experience, at least in Orange County, in all the major hospitals would be very, very similar. But that's only been in the last few months. Before that, there was wide variations in how they would treat you. And even though this is the last one, I'll be happy to take other questions. The reason we did this, beside the fact it's a little easier for us here, is that, and this will be the case next time if you're planning on coming to the vaccine talk, I just don't want to take any chances of getting into a thing about anti-vaxxers. If you're an anti-vaxxer, I just need you to leave. I don't engage anti-vaxxers, and I really didn't want to get in a shouting match if anybody wanted to raise their hand. Is Decadron or prednisone? I assume you mean, is it effective? Well, Decadron is dexamethasone, if that's the question. Who asked this one?
I'm not sure who, but if I
That's what I answered.
correctly.
Is it dexamethasone or prednisone?
Well, they've not studied prednisone, surprisingly, with COVID. Medrol, yes, and Decadron, yes, and Decadron is dexamethasone. But prednisone hasn't been studied. Now, some patients asked us for prednisone when we were starting steroids because they took it when they were asthmatic, they took it when they were kids, and they're comfortable with it. So we did give a pretty healthy dose. For those who've taken prednisone, we usually started at 40 to 50 and even went to 80 or 100 of prednisone. That's a pretty high dose. But we found for COVID, the higher dose steroids really worked much, much better. I'm happy to take any other questions now, or I can do it privately if you'd rather.
Significant difference between a high-dose steroid versus NSAID?
Oh, no,
High-dose NSAID, is that just
it's,
because OTC versus
no,
injection?
it's a poodle versus a coyote. They're two totally different things. An NSAID is N for non-steroidal.
Right.
So an NSAID is not steroidal. Steroids are steroidal, and then high dose is even more. The idea is high dose steroids is very dangerous taken long term, but short term it can be a lifesaver. So that's why we gave higher doses of Decadron, because we're trying to keep these people from being intubated, basically. So.
But NSAIDs can be dangerous too.
Oh yes. Well, they don't recommend. They I think now they're more neutral, but last year they actually told us not to use NSAIDs for COVID. There was no evidence it worked, and so use Tylenol and don't give Advil and all that. So
How much vitamin D?
2,000 would be minimum and a day, and that's what I'm taking currently. But there are prescription strengths that go up to 50,000, and some doctors are using that. So I would say 2,000 minimum, and there's no danger going to 3, 4, 5,000 a day. Can I answer any other questions? I'll be happy to stay. Talk
Can I
privately.
ask one question, because
You may.
a couple people have asked, regarding those that have had the COVID vaccine and getting their antibody blood test, and some are saying reactive and non-reactive, and it's kind of all over the board.
Thank you for coming. We're done for the questions for tonight.
Multiple people have asked, so I know it's next talk, but in the interim. what's
Well,
next?
so I'll answer the best I can. Last fall, my understanding was that the vaccine would give you the antibodies that are checked by the lab. We have two different tests we use. We have a test we send off to LabCorp and Quest, and then we have another one we can do right on site from a lab, and they pick up antibodies. And so I was telling people who were about to get the vaccine, don't get complacent after the vaccine. Check your antibodies. It's not going to last forever. But it turns out there are different kinds of antibodies, different types, and there are people who get good antibodies, but they're not picked up by the blood test. So he's flip-flopped so many times, I hate to use him as a source, but Dr. Fauci and the CDC actually came out and said, don't bother checking your antibodies if you've had the vaccine, because it might give you a false sense of insecurity. Meaning if it's positive, you're pretty happy, but if it's negative, you say, oh my God, I took the vaccine for nothing, but it's still protecting you. As evidenced by the fact that 99% plus of people with the vaccine fight off COVID. So enough patients have told me they want to continue getting monthly antibody tests, even though they were vaccinated, that we're doing that. The vast majority, I'd say over 80, 90% are coming back positive with antibodies. So I think it's wise to assume you can pick up the antibodies on the blood test, but it's possible to have good antibodies and not pick it up.
Thank you.
Okay, I'll be happy to hang around, and if anybody